No two COPD cases are alike. That's not a slogan, it's the data. COPD, chronic obstructive pulmonary disease, isn't one disease so much as a cluster of lung problems that look similar on the outside but behave differently on the inside. Two people can cough, wheeze, and feel breathless, yet the biology driving those symptoms can be wildly different. Think of the lungs as an ecosystem. In one person, the airways are inflamed by neutrophils, frontline immune cells that act fast but can damage tissue. In another, eosinophils dominate, cells linked to allergic pathways and steroid responsiveness. Same label, COPD, very different biology. Why does that matter? Because treatments target mechanisms, not names. If your inflammation is mostly eosinophilic, you might respond well to inhaled steroids. If it's neutrophil heavy, steroids may do less, and other strategies, like macrolide antibiotics or biologics under study, could make more sense. This is precision medicine, tailoring care to your biology. Instead of asking, what's the best treatment for COPD? I ask, what's the best treatment for this person's COPD? How do we tell the difference? Biomarkers. Blood eosinophil counts, often a clue for steroid response. Exhaled nitric oxide can hint at airway type. Sputum analysis reveals which immune cells are in the fight, and imaging, like high-resolution CT, maps emphysema destruction versus airway disease. Zoom in further, and you see DNA and RNA, genetic variants that nudge risk, and gene expression patterns that show which switches are flipped on in your lungs right now. Not destiny, just probability and pathways we can measure. Even smoke exposure isn't the whole story. Some lifelong smokers keep surprisingly stable lungs. Others with moderate exposure decline quickly. Genetics, early life infections, air pollution, occupational dusts, and even the microbiome add layers to the puzzle. So what does tailored actually look like? First, accurate phenotyping, spirometry for airflow, imaging to locate damage, blood or sputum biomarkers to profile inflammation. Next, targeted therapy, inhales chosen for your pattern, oxygen if needed, pulmonary rehab to rebuild endurance, vaccines to prevent setbacks, and, when indicated, add-ons like macrolides or biologics in trials matching your biomarker signature. Finally, continuous feedback. Track symptoms, track exacerbations, track biomarker trends. Adjust as your biology and life change. This approach doesn't replace the basics: quitting smoking, staying active, managing comorbidities. It refines them. Fewer flare-ups, fewer side effects, and care that matches you. Not an average patient in a study from 10 years ago. Here's the bottom line. COPD is a name. Your biology is the story. If you live with COPD, ask about phenotyping and biomarkers. Data isn't cold, it's personal, and it's how we breathe smarter. No two COPD cases are alike. That's exactly why precision matters. Please, like, share, and subscribe.